Good evening and welcome to this very special event brought to you by the American Journal of Managed Care. My name is Brian Haug and I am the publisher of AJMC and Evidence-Based Oncology. Dr. Jeff Prescott, our Senior Vice President of Clinical Affairs, who will be moderating the Q&A portion of tonight's event, joins me as well. On Friday, November 16, 2012, the American Journal of Managed Care and Evidence-Based Oncology hosted its first annual live meeting translating evidence-based research into value-based decisions in oncology. The conference provided an opportunity for the nation's premier thought leaders in the payer oncology space to discuss, explore, and help define value in cancer care through the use of best practices, clinical pathways, and evidence-based models. Tonight we are excited to have four of those experts with us. Dr. Jeffrey Dunn from Select Health, Dr. Cliff Goodman from the Lewin Group, Dr. Ira Klein from Aetna, and Dr. Mark Fendrick from the University of Michigan. Mark is also our co-editor-in-chief here at AJMC. Our esteemed panelists will be answering your questions in just a moment. However, to help us get a head start on that, if you have a question for our panel, please email it to us at questions@ajmc.com. That's questions@ajmc.com, which will also be up on the screen during the session. However, before we get to our Q&A, I would like to take a minute to show off something I'm very proud to present, and that is the online home for the enduring content from our live event in November. The URL for the microsite is www.ajmc.com/live meeting, and it is available right now. But don't go anywhere just yet. The page is very accessible from the AJMC homepage. Let me just get this up. Okay. Now that we have the web page up, I wanted to point out that we have full video coverage from the meeting, so you can experience Cliff Goodman's informative keynote address, amazing presentations by each of our other 6 faculty, and an amazing and dynamic panel discussion also moderated by Cliff. Each presentation is broken up into smaller files to make things a little more digestible, and everything is formatted to play well on mobile devices and iPads. So after our webinar tonight, please feel free to check out the site and share the links with your colleagues. That's it for me. I will now turn the program over to Dr. Prescott for the Q&A.
So I have a question that came in. How do we incentivize medical professionals to go along with quality measures or practices, basically high quality performance in the area of oncology? And I will put that one to Ira.
Well, that's something we've thought a lot about, and we really think that oncologists are uniquely courageous in treating patients who are medically complex, who have diseases that are frequently fatal, and doing so in a time period that is not just a 1 week or 1 day period like a trauma surgeon, but over a period of years. But one thing that is common amongst oncologists to other medical professionals that we've seen is that incentives need to be in one of 2 forms. Those are either some financial incentive that says to the oncology practice, we have a path for your economic survival into the future, hopefully a little bit more money than today, but at least the ability to plan and be in existence. And 2, things that can be done to reduce the hassle factor in the oncology practice. And because there have been criticisms, and not incorrect criticisms, of the intrusiveness of managed care, that's how the management happens, if we have ways of reducing those hassle factors, that's very attractive to an office because it means several things. It means a reduction in the number of full-time equivalent personnel in the office needed to manage those hassles, be they pre-certification, network navigation, other referral type issues, or those that have to do with the supply chain of drugs. And also it means that patients can be more the focus of the office work rather than the maintenance of contractual obligations to the payer. So those are things that we found to be effective. As was described earlier by several people, things are pretty complicated in cancer, and so it's hard to translate that into a strategy, but that's what we're looking to do.
Okay, thank you. Let's see what we got coming in. With regards to the movement towards more oral medications in oncology, and I'm going to, since this is a nice pharmacy question, I'm going to ask Dr. Don Jeff, if you can comment that. What are some strategies or thoughts or concerns around compliance in oncology? Is that a valid role, or is that a concern that you have in the payer side?
I'll give you the honest answer. I don't, in the foreseeable future, see us having a compliance program in oncology. This is something that, given the cost of the medications and the issues around objective outcome measures and what's a response, what's not a response, all of those kind of things, I don't see it happening. I think actually you're going to see more of the reverse occurring, things like more split fill programs and more emphasis on stopping therapy at end of life and those kind of things. So I don't think the traditional specialty pharmacy programs apply to oncology.
Okay. Well, can I ask anyone, Cliff, what do you think about that?
What I think does matter, though, is this, that whether it's in oncology or other areas, policymakers and payers are going to be more interested in paying for demonstrated improvement in health outcomes, however measured, than they are for the molecule, and so big or small. And so adherence starts to matter more that way, and more stakeholders have a stake in adherence, because if they're going to get paid based on outcomes more often, then they do care if the patients adhere. And so I think that may ratchet up the interest in improving adherence using various approaches. Now, whether it's oral or physician administered, what have you, I do think that patient preferences and abilities do matter, and adherence may be tied to, and this isn't really a form of personalized medicine, what's the form of delivery that best suits that patient, and how do we tailor that to the patient? But I just think that more stakeholders will be oriented toward adherence when they get paid more often based on the patient outcomes.
Jeff, if I could add to that, this is Mark Fendrick. I want to echo Cliff Goodman's comments and just remind the audience is that the most expensive therapy is the one that doesn't work. And while we are constantly dealing with pressures and tensions between cost and quality, I think this simultaneous movement that Cliff Goodman mentions about moving from volume to value, coupled with important supply side or payment levers, getting away from fee-for-service to one that tends to focus on specific outcome, would in fact push various stakeholders, maybe less so the health plan or the health system, as Dr. Dunn notes, but actually turning to the ultimate payer, that being the employer, to make sure if they're going to make an investment, whether it be a small molecule, relatively inexpensive lifesaver like tamoxifen, or some of the very high-cost specialty drugs that Dr. Goodman mentioned, I think what we don't want to see are inappropriate courses, half-filled courses, or really big gaps in opportunities for improvements in health outcomes and healthcare cost reductions that would come from the unfortunate decreased utilization of high-value evidence-based care.
Yeah, and this is Jeff Dunn again. Maybe I can bring us back full circle. It might sound like we're saying different things, but I actually think we're saying similar things. Is the traditional models are not applicable. The turfing this off the specialty pharmacy and having them call the member at 28 days and saying you're late, or we're going to auto ship you your $10,000 a month drug, is going to be driven by the change in responsibility and payment reform and the ACO and all that kind of stuff, where the incentives are different, and it is paying for quality. That's going to be driven more by the provider and the plan, and not necessarily the traditional measures that are in place right now.
This is Cliff again, and I'd pose it to Ira. Ira, if you know that there's CML patients out there that could benefit from Gleevec, which is not the cheapest drug out there, do you have any reservations about getting them a Gleevec? I'm betting you want them to take their Gleevec.
Yes, we do. And one thing else that we want to happen is, in terms of adherence, as Dr. Fendrick said, we want adherence to the right therapy. So adding to the job of whomever takes this on, and as was said by Jeff Dunn, it's not so straightforward in the usual specialty pharmacy world. We want to have the right companion diagnostic test done. So just add that onto the list of things that are hard to get done and verified and validated.
And if I could pile on sorry, Jeff, talking about this full circle. I think that we tend to talk about demand-side initiatives, that being benefit design, literacy programs, adherence programs, in a vacuum relative to the exciting and a lot of unknown in what's going on regarding supply-side interventions and payment reform and the models that Jeff mentioned. I think it's very important for us to mention early on that one of the reasons why we have examples from Aetna and Intermountain Health here is because because these are two organizations that have worked very, very hard to integrate supply-side initiatives, what you're doing with the health systems and the physicians. I call that peanut butter. With demand-side initiatives, such as benefit design and adherence programs, I call that jelly, and really trying hard to make sure we see the magic of combining the two into something where the sum is really greater than the individual part.
Yeah, this is Ira. I think you need both. You cannot really get it done with one. Thanks, Mark.
Okay, I think we have time for one last question, and this one is coming from me. So we've been hearing more about clinical pathways. I know that was something that Bruce Feinberg spoke about in the live meeting a while back. You know, thinking about clinical pathways, we talked about many different tumor types and cancer types, and obviously some of them are more homogeneous than others. But for some of those more discrete cancer types, how do we go about putting together best practices or clinical pathways for those? I'll throw that out. Who wants to nibble on it first?
This is Ira. I wanted to clarify, when you say discrete cancers...
I would probably say not some of the more common tumor types.
Oh, okay. Something that is infrequent but easily describable from a tumor cell surface marker perspective and clinical presentation perspective?
Yes, much better said than I, so thank you.
Well, everyone on the call knows I'm not an oncologist, but...
But you play one on TV?
I play one, yes. I stayed at the Holiday Inn Express last night. Those types of situations are easier to approach because it's very well agreed by all what the appropriate approach is, which then can fit neatly into some type of solution that makes sense for payers, providers, and patients. As Mark said earlier, in building the peanut butter and jelly sandwich, you have to know how to approach each side. I think an example of that would be when we are looking at patients who need a particular therapy for melanoma, and we have a drug that requires a certain cell marker. You can only get the drug if you have a certain result of the test. You know, there's a few examples out there. I'll give it over to others to elaborate.
Yeah, this is Jeff Dunn. I think it comes down to a combination of prevalence and the number of drugs we have. And I don't think we'll have pathways, and we'll never have pathways in all cancer types. You know, we're going to pick, you know, the ones that are going to have an impact to the bottom line. I think a huge unmet need right now, though, is we need more and better data from people who are using pathways right now that can reinforce what we're doing, that can expand the process and justify some going into some of these other areas. And I personally don't think we have very good data from pathways right now that's generally accessible.
All right. Well, I think we're up for time for tonight. We have everyone on the phone. Any closing comments? I'll start with Mark.
I was very pleased to join this panel. I think that it's interesting to see conversations and publications and issues that we've dealt with the American Journal of Managed Care across the entire spectrum of clinical services, and focus on one of the most common, costly, and controversial, that being applying some of these levers to improve quality and increase cost containment in cancer. And it's wonderful to have a multidisciplinary group of experts who are helping move these discussions forward, identifying opportunities, but also realizing that substantial challenges remain.
All right. Thank you, Mark. Cliff, anything as we close things up?
Sure. I think you're seeing a couple of lines crossing now, and one is that the price of cancer drugs has gone up in a way that does not reflect demonstrated value. And there's been a lot of tolerance of that historically, but I think as demonstrated by that interesting case with the colorectal cancer drug on which Memorial Sloan Kettering pushed back in November, you're seeing this pushback now on those high prices at a time when comparative effectiveness and other requirements for evidence are rising. So high-priced cancer drugs are confronting now much more scrutinizing decision makers and policy makers. And I think you're going to see a lot of movement now insofar as the valuation of cancer drugs, how specific we do that, how explicit we are. I think you're going to see that reflected in coverage decisions and payment decisions.
All right. Thank you, Cliff. Ira?
Well, I would like to say that I think that there's a huge need to collate, sort, after we gather more information about the existing pathway programs that really are not in a mature state. They're, most of them, only 2-3 years in existence and covering primarily the common cancers, breast, lung, and colon, all of which have multiple subtypes of their own. And when we get this information, Jeff pointed this out earlier, it'll be like sand that we need to fill sandbags, and we'll have to be piling those sandbags up on the riverbanks of a rising river, so as to address the issue that Cliff talked about, which is a flood of unsustainable costs because of drugs that we don't know what the value are. So we do need to keep working on gathering information, sorting it, using it to figure out what are the right therapies, when are they appropriately applied, and as soon as that information is available with enough weight to allow it to be applicable, we'll put it into action. But this is evolving and ongoing, and without the data, we can't do it.
All right. Thank you. Jeff?
Yeah, similar answers to the last few. The old solutions don't necessarily work here, and this is going to be very, very challenging. Value and cost-effectiveness analysis here is totally different than what we've seen before. Collaboration is going to be key, data is going to be key, and we need to start addressing some of these issues, and where we start is forums like this, and hopefully now we can start taking next steps and implementing some of these things. So I appreciate this opportunity. It's always nice to hear from other people, to get their impact, and to learn from what other people are doing. So thank you.
All right. Thank you, Jeff. Well, I would like to thank our panelists tonight, Dr. Goodman, Dr. Klein, Dr. Dunn, and Dr. Fenrick. Thank you for your time this evening, and of course working with us in our live meeting earlier in November. It seems so long ago, a whole year ago. But also for our listeners tonight, we will be having this live meeting again next year, next fall, around the same time period. Please check back at ajmc.com for further details. And as Brian mentioned, the highlights video recap of the live meeting from November is up and available at ajmc.com/live meeting. And of course, we're going to have lots of coverage on it on the website. You can't miss it if you visit the homepage. So thank you, everyone. Have a good night, and we'll see you next November.